session. So, Dr. Santos, the floor is yours now.
Thank you for the introduction. I would like to say that it's an honor for me to be a panelist in this session. And we're going to start by following the learning objectives that were stated by the session. We're going to start to consolidate knowledge regarding the current radiation dose values used in CT, past to the optimization measures using scanner technological factors, and then analyze the impact of dose optimization on patient dose and image quality. So it's well known that CT is responsible for a large proportion of effective collective dose across the countries. European countries have studied this recently. However, we know that worldwide CT examinations are performing in a large number. So, starting by the first topic, analyze the current radiation dose values used in CT is mandatory. The CT dose values could be described in different modes, and sometimes we hear to talk about dose when we talk about patient dose, organ dose, or examination dose. Patient doses normally are described in effective dose and presented in millisieverts. Organ doses are also presented in millisieverts, and they could be measured or they could be software calculated. Examination doses are described for CT in CTI vol and DLP values, and they are available in our CT scanner all days. But it's important to know what kind of dose values that we are looking. We need to analyze what kind of CTI vol that it's available on our CT scanner. For example, if you are using a CT scanner that represents the CTI vol for body examinations, you should have included the indication of the patient size. This is an example of the dose report from Siemens indicating the size of the phantom. Or, for example, if you are using a General Electric CT scanner, you should also analyze the information about the phantom that was used to calculate CTI vol. It's also important to state that if you are looking for pediatric CT examinations, CTI vol calculations must have a factor of 2.5 included. CTI vol also have a lot of limitations. We all know that CTI vol represents a value for different patient sizes, and it's important to analyze, especially for body regions, the impact of the patient size in these values. For this, you could use specific size dose estimates that is based on the conversion of the CTI vol values using a conversion factor to calculate SSEA. CTI vol is also useful to calculate the DLP. DLP values could be calculated based on the range size of our examination study. And DLP values could be useful to calculate effective dose using the corresponding key factor of this specific body region that we are studying. The most common CT dose descriptors still are CTI vol and DLP values, and they are used to calculate diagnostic reference levels. Diagnostic reference levels can be calculated in a retrospective mode based on the DICOM header information or on a PAC system, or in the prospective mode based on the patient or phantom data. It's important to note that if you are calculating this in a retrospective mode, sometimes you don't have enough data about the patient size, and you could have different types of patients included in these calculations. However, this method is very fast and simple. To calculate DRLs on the prospective mode, you must be aware that it's hard to obtain standard patient sample. And if you do it using phantoms, the obtained value is not so real. So this method is more time consuming. Don't forget that at the moment you have a lot of dose monitoring systems that could calculate the DRLs for you. However, it's important to understand how they are calculated and how to interpret the data that you obtain with these systems. So if you want to calculate your local DRL, you should calculate it based on the 75th percentile dose values of CTDI and DLP. If you want to calculate the national DRL, they were based also in 75th percentile dose value, but calculated based on the P50 of the values of the dose of the different sizes. And for example, for the European DRL calculations, they were based on the P50 of all the national DRLs. At the moment, the new approach for DRL's calculations should be the clinical imaging task, and you should focus on the standard patient group. So, what is a standard patient? If you are looking for adults or if you are looking for pediatric, standard patients have different points of examination. If you are talking about adults, you must analyze the height and the height of the patients to select a standard patient. If you are looking for pediatric, you also need to include the age of the patients. And recently, you have more information about the pediatric categorization, but we also had groups based on age, on the European guidelines, and now at the moment, using the PyDRL data, we analyze that the patients should be characterized according to the patient age for body CT examinations, and if you are studying head CT examinations, you must use also the age of the patients. So the DRL is calculated based on the 76th percentile of the dose values, and this should be the value that you compare with other studies. However, it will be useful for you if you could use the 95th percentile dose value. That could be considered an alert value for auditing. Also, the P50 could be useful if you are trying to optimize your DRL and you want to be lower than this value on your daily practice. The most frequent CT procedures are head, chest, and abdominal studies. And for these values, you found a lot of literature that represents different diagnostic reference levels. You should select one of these to compare with your daily practice. However, there is a lot of variability on the DRL's calculation. We all know that they are based on standard patients. However, when you look across the countries, you're going to see that DRLs for the same body regions, this is an example for head CT examinations, could be very different. And if you are looking for a specific clinical task, as Eurosafe Imaging proposed recently, for example, if you are looking for acute stroke of a head CT examination that was performed with a specific clinical task, or another example, if you are performing a chest CT for the pulmonary embolism indication, you can see that a large variation on the dose values could be found, and you could have 3 times more dose in different in different examinations. So it's important to understand that DRLs have a large of variability, and you need to analyze your daily practice and plan and compare, measure again, and do it in order to optimize your practice and audit your values as is stated on the recommendations of the European guidelines for clinical audit. So you have your local DRL, and then during the time you decide to optimize your practice, you decrease your dose values, and you optimize again. And during the time, the expectation will be to decrease dose and decrease the risk for the patients that are submitted to examinations in your department. So DRLs have a lot of challenges. One of the challenges is the dose descriptor that you're going to use, analyze correctly if it's properly defined in your CT scanner, define the body regions that you wanted to study, select the characterization of the patient that you wanted to use, and analyze your type of informatics system that you have available in your department. And of course, if you wanted to do it also based on the clinical indication that you suggest that is more frequent in your department, and taking into account the CT scanner technology that you have. So it's important to know how to use your CT scanner to promote optimization. We all know that CT scanner design features have changed in the years. In the last decade, they were prepared to increase the capacity to be more faster and to get more finer details in the images. However, recently, in the last years, they pretend to try to get tools to reduce those and maintain the image quality. Independently of the type of the scanner that you have, you could use different optimization tools that are available in all the scanners. For example, the ISO center. ISO center is quite obvious. Of course, you need to put the patient on the center of the gantry. However, sometimes it's not happen, and you could have high dose values or you could have high noise because the patient is not proper positioning. So it's important to state that this is the first step, positioning correctly the patient on the ISO center of the gantry. Other thing that is important, if you are using modulation system, the function of the system will work properly if you put the patient on the ISO center. Considering the point that I presented you before, if you want to calculate SSDE for the body CT examinations, you're going to have a scout effect. The scout is going to increase, and you're going to take the measures of the patients, and they will be also increased. And the calculation of SSD will be with an error because you increase the dose because of the incorrect positioning, and you will also increase the noise because the patient size will be affected on the scout view calculations. If you want to know more about this, the importance of put the patient on the center of the gantry, you could go to Eurosafe website and check the CT working group reports. About the range size. Range size, it's not depending on the technology that you have in your CT scanner. And you have on the IAEA 10 pearls an indication that you should adequate the size of your range according to the clinical indication. For example, if you are performing a chest CT examination, you could have a dose reduction if you would equate the size of the range, and you could have a reduction of 20 to 30%. Other studies indicate that for example, for lumbar spine, if you would equate the range to the size of the clinical task, you're going to have a reduction that could go until the 50% of dose reduction. So it's important to adequate the range size according to the clinical indication, because we know that increasing the range size in 1 centimeter or, example, 2.5 centimeters will going to correspond to a higher exposure. And for example, you could see here that it could correspond to our examinations that the patients could perform with clinical needs. So it's very important to adequate the range according to the clinical indication. Multiple phase protocols are also a problem. IAEA indicates also that multi-phase protocols must be avoided because they directly increase the patient dose. And it's important to understand that you should just use it when you need it. Recent studies indicate that D-phase protocols could also be used, and especially for abdominal studies, and you could have two moments of delay with a single acquisition, and you also have a D-phase protocol study, and you don't have to expose the patient twice. You could also have more information about this topic, about B-phase injection protocols, on CT working group from Eurosafe campaign. Range and phases must be analyzed according to the clinical task because they are directly connected to the DLP value that the patient will be submitted. So you could find different clinical indications and different indications of the laying size that you should use according to these tasks. And they should be both combined. So selecting the exposure perimeter is the most hard task to have a correct CT examination. We all know that all of us want to have higher tube voltage, higher tube current, and higher Gantt mutation time because these parameters will help us to have the best image quality. However, all of them are proportional to the increase of the dose. We also want to have the lowest pitch as possible to have all the details of our body region in study. However, we also know that this decision had a relation to increase the dose. So it's important to adequate all the exposure parameters to the examination that we are performing. To help us, some new tools are developed in our CT scanners. For example, you could have a tube voltage modulation. It could have different names from different brands, but of course, at the end, they want to decrease the dose. And they are based on the patient size and also based on the clinical indication that you have to perform the exams. So you could have a lower examination dose values if you have this tool in your CT scanner. However, if you don't have it, you can reduce the tube voltage in some procedures that you normally perform with 120 dBs. So the most known optimization tool is the tube current modulation. It also depends on the type of CT scanner that you have. It could be based on the patient size, it could be based on the z-axis variation, it could be based on angular variation, or it could combine the z-axis and the angular variation together at the same time, and you will decrease the dose in your examination. If you have a CT scanner that could combine the modulation of the current and the modulation of the voltage at the same time, you're going to have a dose reduction that is higher than 50%. So it's important to be aware, if you have this technology in your scanner, you must try to understand how it works and take advantage of that. Recently, in some of the CT scanner, we already have interactive reconstruction. With this type of technology, we have already data in our sinogram of our original imaging. So with this, we just have image acquisition to obtain information to correct our pre-information that is available on the sinogram. So it's possible to reduce the dose because you already have information when you start to perform your examination. If you want to have more information about interactive reconstruction, you also have a report written down by the CT working group available on Eurosafe website. So interactive reconstruction will allow you to have artifact reduction and also to have better low contrast resolution. However, using interactive reconstruction, it's sometimes hard at the beginning and you need to have specific training. For example, if you have feature-back projection and then you pass to have the tube current and the tube voltage modulation, you could obtain a 30% of dose reduction. But if you have interactive reconstruction available, you could also reduce the dose value that you already had before. Using interactive reconstruction is like making a decision in all the exams because you need to select if you want to maintain your image quality and have a lower dose, or if you want to have the best image quality with the same dose that you already used before. So this decision must be taken in team to analyze the situation of the patient and to analyze if you, in this specific case, you could have dose reduction or if you need to have a high image quality. So the definition of protocol is a thing that you read and you know that there's a lot of papers that talk about it, but you need to adequate this to your specific scanner. You need to know how your equipment works. And with this, we are prepared to adequate the protocol to the patient motion, to the small structures, and to the low contrast structures. It's hard because we know that we need to manipulate the exposure parameters that directly going to increase the dose. And at the same time, we want to have high image quality and lower dose and non-artifacts included in our image. So you have to take a lot of decisions. And at the same time, you need to think and the clinical tasks that the patient have and the specific characteristics that the patients have when they come to your department. So for each examination, you have a lot of decisions to make. It's important to be aware of those optimization measures. However, it's also important to analyze what happens to the patient dose and to your image quality. Looking for image quality is like going through a balance when you want to have lower dose or high dose. If you have high dose, of course you're going to have high image quality. However, it will be good for your patient. And if you want to balance to have lower quality, you may miss a diagnostic. And of course, at this moment, you need to think what is happening in your dose. So it's important to balance, and you have to handle it with care. And for each examination, you have to think how to balance between dose and image quality, because you are looking for the image that allows you the diagnostic. So image quality must be analyzed in two different modes, but they should be together. They should be analyzed in objective mode and also in subjective mode. Objective mode normally is performed using image processing tools, and subjective mode normally is performing using the clinical professionals involvement. So before you start to analyze your image, it's very important to analyze the conditions that you have when you are performing reporting. For example, you need to check your monitors, and you also need to check the environment that you have when you are reporting. It's important to understand if the luminance ratios are according to the indications for a primary monitor. And it's also important to understand if the conditions for have a good report are maintained during all the analysis and if they are correct for each specific image modality. Another important thing is the observers that you're going to have. You need to select observers with similar experience. They should have more than 5 years of experience, and they should be aware that they are looking for specific criteria. If you are performing objective image analysis, normally you could have 8 points that are recommended on guidelines. You could perform your objective image analysis in different modes. You could perform it for quality control phantoms, with anthropomorphic phantoms, or inpatient images. If you have the quality control phantoms, sometimes they have a software that allows you to have all this information, all these points that you could analyze in automatic mode. If you don't have it, you could use an image processing tool, and you could perform ROIs in homogeneous areas and analyze the noise and the signal and also the spatial resolution and obtain all the information from your image. You could use this on anthropomorphic images or on patient images. Subjective image analysis, it's a little bit more hard to perform because it not just depends on image processing. So you have to have observers included, and as I said before, they should have similar experience. But if you have more than 3, you could also have different types of observers. They could be from different professional groups. It could be also interesting. And it's important to use the correct imaging criteria. For example, on European guidelines, you have tables that indicate imaging criteria per each CT examination. For example, here you have the quality imaging criteria for head CT examination, these 5 points presented on the left, and then you have a scale that indicates if this criteria was fulfilled or not fulfilled. For collecting data of subjective image analysis, you could use software that helps you to calculate the imaging criteria score that was performed by the observers, or if you could do it without software, you could do it with a handmade. After you have the data, you need to use specific statistical examinations. It's important to understand that you need to compare the criteria that each observer used and if the imaging criteria are being fulfilled. The most frequently used methods are the VGC analysis using rock groups analysis to compare if the optimized protocols are fulfilling the imaging criteria that you have on your guidelines. Of course, that if you compare your subjective image analysis and your objective image analysis together, you could have a comparison about what is happening into your image in terms of quality, considering that you have changed the protocol. However, there are guidelines to change the protocols. You could look, for example, on this scheme, and you see that you need to be prepared to meet. A lot of times you need to have discussions with different professionals that are involved on the CT examination performed and reported, and also try to change just 1 point at a time, and then analyze the image and then discuss again what is happening to your image quality. With all this data of image quality analysis, you will be able to change your protocol. So you are trying to change your DRL. You have obtained your DRL for a specific CT examination, and you want to optimize the DRL. You are trying to balance this radiation dose and image quality. However, you need to do it in the teamwork, and the clinical task and the specific patient characteristic must be analyzed in order to define the correct way to optimize the procedures. So, in conclusion, knowledge and training in CT promotes good practice. Analysis of the dose values and image quality is mandatory during the optimization of our procedures, and CT optimization measures must be effectively used in our daily practice in order to promote the patient safety. We all know that medical imaging saves lives, however, they should be optimized. So, thank you for your attention during the session.
Thank you, Dr. Santos, for this very comprehensive presentation covering different aspects of optimization of CT procedures. For me, one of the main messages, in addition to the technical aspects, is the importance of the team approach that you highlighted several times. So we need, of course, radiologists, we need radiographers, we need medical physicists in this process. We have already questions, so we can start reading and answering them, and I invite the participants to ask questions or submit comments. Can you see the first comment? We have in the chat box a comment that I want to start with from Dr. Vesna Gershon, focusing on the need of standardization of the names of the city protocols. She says, we faced problem with non-standardized city protocol names among hospitals. This complicates things towards setting of DRLs, so city protocol names should be unified, and some international effort is very welcome. I think this is a problem that everybody who starts with not only establishing DRL, but also in those monitoring problem faced first. So I would like to ask both speakers to provide comments on this.
Could I intervene, Diana?
Yes, please, Professor Fraser.
Okay, so I think this is a very important question. And the recent trend in the European Commission and also into Eurosafety imaging was to say that instead of having DRS, which currently are based on anatomical location, to speak instead of clinical-based DRL. For example, if you take a chest CT, and if you are performing a chest CT for pulmonary embolism, or for coronary calcification scoring, or for lung nodule detection, you know that the protocols are completely different. And therefore, we think, and it was our, I would say, what we asked to the European Commission, and we have been followed in that, to limit the concept of DRL to some frequent clinical indications. And the European Commission has launched recently a tender, the name is Euclid, with a purpose to establish the first clinical DRL in CT. And I can tell you that we have decided to limit the scope to 10 to 12 clinical indications. And therefore, the problem of standardization of animal protocols is probably completely overcome, because if you are speaking about pulmonary embolism, I think that everyone knows what is the pulmonary embolism. There is no problem of translation between French, German, Italian, and other languages. So I think that we are today in an era where institutions are understanding that the classical DRS are very difficult to manage, and they are starting to focus the attention on the most frequent clinical indications, and therefore to limit the problem of name standardization.
Thank you. Joanna, would you like to?
Can I comment also? Okay.
Yes, thank you.
Yeah, and I think that it's hard because we have, even for each specific country, different codes that we use for CT scanners, for CT examinations, sorry. If you go trying to collect data in the different systems that we have, you could find that the professionals don't use the same code, even in the same institution. So when you are trying to get a specific study, you don't find the correct data that you are expecting. Of course, that the point that Professor Friedrich focused is very important. We need to think in DRLs in a different approach. We need to think on all the clinical tasks, starting by this fixed approach that Eurosafe presents on the website could be a good starting point.
Thank you. I think this is really an important question that we in the IA, in collaboration with the societies, we can work further on. There are a few more questions and more are coming, so can we continue? Can you see the questions in your Q&A box?
Yes.
Yeah, you can read and answer if you prefer. Or, yeah.
Okay. I have here a question that says if we think that the CTDI files and DLP must be incorporated in routine CT reports. In some countries, it will be already mandatory in a few months. In Europe, it's mandatory to have this information in the reports. But it's very important to know the URLs that we use in our department. I think that is more important to have it on the report. It's to compare the examination that I have performed with the URL that is established in my department. Okay. Dr. Fringe, do you want to comment, or can
I don't have any comment on that.
Okay.
So I can see your question on my screen.
Yeah. Okay. There are another question about the CT scan. Those differences between the fan beam geometry and the cone beam geometry. If you are talking about the CBCT images, for example, you don't have the same dose description in some of the scanners, so you cannot compare the dose that you are using for the same procedures. Normally you are using CBCT images for radiotherapy planning or for oral imaging, and this type of acquisition should have lower dose values. However, I think that this sometimes it don't happen, and you have higher dose values than you expected for.
Okay. Yeah, just a comment. We are planning in future a webinar dedicated to the dental cone-beam CT, so this may be of interest for the participants when we'll focus on this new, relatively new technology.
Yeah. Other question that is presented here, it's about the subjective image quality analysis. I have some experience to perform this in my studies. A tool that I indicated was the European guidelines that have tables for the specific body regions that we are studying, but I think that we have a lack of imaging criteria, especially if we going through this clinical indication approach. Maybe we should also have in the future clinical imaging criteria based on the clinical task. Okay, but to start at the moment, for example, if you want to start now, you could go through the guidelines. The European ones have at the end the tables for each specific body region, and you could analyze if the criteria is fulfilled or not fulfilled. And you have scores there, you could analyze how to do it.
Professor Frisia, can you see the question about the Eurosafe imaging?
Yes, there is a question, but whether Eurosafe is a branch of the image sensing, is right?
Just to clarify the difference, yeah.
No, Eurosafe is completely independent. Image sensing has been established in America, and Eurosafe established in Europe, and the goal of image sensing is mostly focused on pediatric imaging, while the goal of Eurosafe imaging is much more holistic.
Yeah, thank you. There are more questions on the technical part. Joanna, if you
Can I send a link of a free way to calculate? Is it possible to do it? Can I write it down on the chat, or it's?
Yeah, you can, and you can address all participants.
Okay.
Just select send to all participants, and everybody can see the link.
I'm not sure if everybody's seeing.
Or you can send to us, and we'll share with the participants.
Oh, it should be on the shop. Okay, already see it. I'm sending. This link that I sent here, it's a way to perform image analysis, the VGC analysis in the free way on the internet. There was a question about it. So just looking for a
There is question on what would you prefer, a DRL with iterative reconstruction or without?
I think if you have interactive reconstruction, of course, it's good to use it and you should compare. But at the moment, worldwide, you don't have interactive reconstruction available in all scanners. So maybe you will compare with a small amount of data, but of course, if you have interactive reconstruction in your CT scanner, you should use it. Okay.
Yeah, to my knowledge, there is no DRL that is specific for type reconstruction.
Yeah.
But probably in future we can do this.
Yeah. Just local studies that have used interactive reconstruction to calculate another recommended DRL, as you said, Jenny. Right. There is one question about pediatric procedures. Yeah. I mentioned a factor of 2.5 for pediatric patients because the recommendations of CTDI vol calculation must be, for pediatrics, must be the phantom size of 10 centimeters and 16 centimeters. However, majority of our scanners have the CTDI vol calculated for adults. That's why when you are analyzing the CTDI vols for pediatric, you should use the factor of 2.5. Okay.
There is one related question about the size of the phantoms for measuring DRL in pediatric CT. In fact, we are not measuring DRL, we are measuring CTDI, but you can answer it. Yeah.
Yeah, you should use the 10 centimeter CTDI phantom for head CT examinations and the 16 centimeter phantom for body examinations. That's our recommendation. However, if you use if you have available in your scanner the values that are recommended for adults, you could use it and then use the factor to perform the calculation.
A question to both of you. The question comes from Brasilia. What is, in your opinion, the minimum team to compose the optimization program?
Dr. Friedrich, do you want to start? Or can...
I don't understand the question.
The
team, what team we need to have in order to perform optimization of CT.
If you want, I could start. Okay? Can I?
Yes, go ahead.
So I think that we must have an integrated team. It's important to, of course, know that we are performing a CT examination to have a report, right? So, of course, radiologists must be included in this team approach. The radiographers that perform the examination must be also included in the team approach, and the physicists should be also included because it helps us to perform the quality and the image quality and also some quality control. So I think it's a team approach. You need to have at least 3 different types of professional. However, it's better if you could include more than one person for each professional group. Not include one of these professionals that should be involved in optimization. Normally, don't take you to the optimization process. All of them are important, the different tasks.
Thank you.
May I say that I completely support that. For example, in Eurosafe imaging, we have medical physicists and radiographers which are working in the same organization. And I think that the access or even availability of a medical physicist is, for me, of utmost importance, because things are going to be much more complex. And also the role of radiographers is fundamental, because the radiographer is really in contact with the equipment of the patient. And I think what it is important is not only to have a team, but to have a common global project. For example, if you are working on optimization, I think that the goal to establish local DRL are extremely important. And what we are considering today, if you are working at clinical DRL, is to take the most frequent clinical indication in one institution and to have a repository, a local repository, on which you could establish your local DRL. And then you could compare with other institutions, or even you could contribute with your data to the establishment of national DRL.
Yeah, I can only support this because this is what we here at the IA also believe, that it's extremely important to promote the work of the team and the optimization. In the team, every team member has the role, and they only add value in the final goal. There is one technical question. Let's say, when will the IDRL report be available in the final version? Do you know this? Can you inform the participants?
I don't have the information.
Okay. Yeah, we only know that the report is has been submitted time ago, approved, but I also don't have information when it will be published. Professor Fija, if you
No, I don't know. We are waiting for the final draft of PIDRL. But I think the most important conclusion is now well known. We need to establish PIDRL. This is maybe the most important conclusion. And I can tell you that on the Eurosec side, we have started a working group on that, and we would try to convince the European Commission to provide some funding for the establishment of PIDRL, because if you want to collect data and so on, this needs organization, manpower, and of course some money.
Okay, thank you. We have quite many questions and only a few minutes left, but we can still address some of them. There is a question about the use of effective dose calculated from DLP, how it should be interpreted in the optimization efforts as opposed to CTDI volume. Joanna, maybe you can answer this.
You should analyze the DLP value, and for pediatric patients, there is a different key factors than for adults. The key factors are characterized according to the patient age. They are available on the last UNSCEAR report, but however they are just presented for the most frequent CT examinations. However, it could be a useful tool if you have a patient that have been submitted to different image modality exposures, because effective dose allows you to calculate, to compare different image modality approaches. There was a question here about, sorry, Jenny.
If I can just add here that according also to the recommendations of the IA and ICRP, effective dose should never be used for individual patients, or it is just additional quantity for risk estimate. And for optimization, we need to use the quantities provided by the equipment, or measurable quantities like CTDI and DLP. And effective dose, it's just additional, at least at the level of knowledge we have at the moment. So effective dose is not the primary quantity in the optimization.
Yeah, that's true. Yeah.
What time frame would you estimate for implementation of local DRL from beginning to end with sufficient data? 3 months, 6 months, 1 year?
It depends on the body region that you are studying. For adult, it depends of course of the frequency of the examinations of your department. But for adult, it would be more easy to calculate DRLs because you could include all the patient ages. For pediatrics, you should have data for 1 year at least because you have to have patients for the different age or age categorizations. It's more hard to have enough data.
Yeah, the sample should be big enough, at least 50, let's say, patients. But it depends on the...
If I may, I think whatever you want to do, I think that it is absolutely important to have at your disposal a dose management system with an automatic dose recording. And I think that people very much be sensitive to that. If you want to make progresses in optimization, you have to buy a dose management system.
Yeah,
whatever the system.
Yeah, I agree that those management system help a lot in all management of data, not only optimization. It could be the data can be used in different purposes. I just want to inform the participants that here at DIA we work on a safety report on guidance on those reporting. We hope that it will be finalized within this year and published later next year. And of course, we cooperate with several international organizations and international experts in that efforts because we know how important it is for the member states to have more guidance on this relatively new aspect. Yeah, I know we have more questions. If you see in your boxes something that we would like to address, otherwise we can ask the participants to send their questions to the emails, to your email. Viviana's email is displayed on the screen now, and also in a few minutes you'll have the patient protection email address. Would you like to see some concluding words at the end?
I would like to just my point of view of I agree with Dr. Frigia in the part of having an informatics system that helps you. However, considering that I have looked for the different countries that the attendees of the session are, I think that it's also important to remember that if you don't have all the technology available to you, you could also optimize your procedure doing in a hard way format. Okay, the team approach it's very important to obtain the complete optimization of the process. And if you can do it by yourself, if you imagine that is possible, you should involve all the different professionals that are involved on CT examinations.
I completely support that. Completely.
Thank you.
Okay, so at the end I would like to thank first the speakers and also the European Society of Radiology for partnering in this webinar. Thank you very much.
Our pleasure.
Our next webinar will be announced soon, and the broadcast has been recorded, and in few days during the probably in the beginning of next week. It will be available for viewing from the webinar page. You can see. You can approach this page from the main page of the ARPO website, going down to the webinars, and you can see the whole list, including today's webinar. I want to encourage you to learn more on this topic by using the e-learning that the IA launched in November last year, and since then we have more than 1,200 registered users and almost 500 certificates of completion have been issued. You can find this e-learning on CT radiation dose management in CT from the training page of the RHOP website. I want to encourage also to apply and to register for the International Conference on Radiation Protection in Medicine 5 years after bomb, with the motto Achieving Change in Practice, that will held 11th to 15th of December this year here in Vienna, in the headquarters of the IAEA. The conference is co-organized with the World Health Organization and Pan American Health Organization, and with cooperation of a number of international and professional societies, including the European Society of Radiology and USA will be also involved. The conference is free of registration fee, so you can submit, you can learn more how to register from the website. You can see the web page of the conference, or approaching the conference team using the email address. So I think with this we can conclude. Thank you for your participation and have a wonderful day or night. You may now disconnect.
Thank you.
Thank you. Bye-bye.